if you think back of the pie that Patricia showed us before, the majority of cancer are sporadic. They occur from mutation that appear somewhere in your cells for reasons that most of the time we don't understand. We all know intuitively that the modern environment we live in, our water, the food, the processed food, that there are a lot of things that probably are not very healthy, but we yet have to put our finger very clearly on most of those factors. Here I mentioned, in fact, just a few elements that have been mentioned before. Low-fat diet, high fiber, lean, exercise, all nice to say. Supplements, that's easy to do. A lot of suggestions, little very solid facts. But if you're not going to eat very well, there's no harm in taking multivitamins or supplements of calcium and selenium. And you may also have heard of the soybean products that appear maybe to decrease the risk of breast cancer and maybe other cancer. We're starting to have cancer vaccines. Beyond the controversy that I hope not to get involved in tonight, you know that there's a papillomavirus that this province, like many other states in the world, have decided to offer the vaccine to all girls before they start being in age of reproduction. There are pros and cons. Those vaccines don't protect against all the strains of viruses, but against those strains, which were the most frequent up to now, they are effective. It's a bit like the H1N1, but that also, I guess, is out of topic. Well, if we're not too sure how to prevent cancer, how about detecting it early? Early detection has been established very strongly to increase curability in many types of cancers. And intuitively, you would think it should be the case in almost any type. But, when you walk back home tonight, ask yourself, am I getting my mammograms on time? Am I getting my pap tests? Am I getting my stool tested for occult blood? Did I have my colonoscopy if I'm above 40 or certainly 50? If I'm a pale skin, is a doctor looking at my skin once in a while to see that there's no funny spot, etc. We don't have time to discuss all the treatments, the standard conventional treatments of cancer, which, despite, what some of my colleagues who are only basic scientists and not an hybrid like me have achieved a lot for us over the past 100 years. And those are surgery if the tumor can be removed entirely and is unlikely to have spread somewhere else. It's radiation. Both are based on, kind of a very medieval type of concept. Your arm has sin, cut your arm, but it works. Chemotherapy, few of you, or I guess in this room, know that chemotherapy was a totally accidental discovery. A ship transporting mustard gas during World War I or Korean War had an accident. The mustard gas leaked, so they quickly came back on shore. And once they were on shore, people discovered, the physicians examined them and did all sort of tests and discovered their blood counts were down. The white cells in particular were very down. So there were people who said, leukemia is a problem where the white cells are too high. Why don't we try to use those mustard chemicals? And that's how all the field of chemotherapy got started. Well, now we're pretty convinced that we have evolved beyond the point of finding treatments by accident. after, I would say, a good 25 years of clinical intense research, starting back in the days of Phil as a young resident, up to just about 10 years ago, we've been trying to use antibodies that are able to attack cancer cells in order to help us cure cancer. And for some reasons, we were not able to figure out how to do it properly. And now there are at least a dozen of examples. The most well-known are the Herceptin for breast cancer, the Avastin in colon cancer, and in lymphoma, in my area in hematology, rituximab has dramatically improved the results, the percentage of cure of patients with aggressive lymphoma. And it has done that in particular in the older patient above 65 who before had poorer results than the younger people. Now the old people do practically as well as the young people. That's democracy. Also, the identification of mutations of abnormal protein made by the fusion of two different chromosomes together has not only led us to understand how that translocation, that mutation leads to a leukemia like chronic myeloid leukemia, but a basic scientist in a university like ours tried to develop an inhibitor that would counteract the abnormal increased activity of that enzyme that was leading to the increased proliferation that's been discussed earlier today. That drug is imatinib, better known as Gleevec, and it makes chronic myeloid leukemia, a disease that normally would have killed you reliably in 3 to 5 years. It makes it a chronic disease. In my office today, I saw several patients that have been treated for more than 10 years with this drug. And we call them designer drugs because it's for the first time we've started to be able to design drugs based on the knowledge of what is wrong at the microscopic molecular level. You heard before of the epigenome. Well, this is not, again, it looks like I'm making it up, but I met today a patient of mine who I saw a year ago. He had been condemned by a couple of my colleagues in other hospitals, and he had a form of myelodysplasia that had transformed into leukemia. Those are exceedingly difficult leukemia to treat, usually. So I said, well, what the heck, let's try to put this end on this new drug that is in kind of the process of being approved in Canada. And there's a special access program, decitabine, and this drug affects the way that the DNA is modified, particularly in the region of the genes that control the expression of genes, called the promoters. And by removing the methylation in these areas, it's able to reinduce essential genes for the maturation of the cells, which when they come back force the tumor cells to mature into normal cells. So this gentleman came to me with 6 platelets. Normally you should have 130. He was bleeding and bruising all over. He had no white cells to defend himself from infection. And now he has practically normal blood counts. And there's other class of those drugs, and I predict we will see more and more of this. Finally, I've spent many years since immediately after I got acquainted with Michel, working on gene therapy, and in particular on how we might one day be able to apply it to cancer treatment. Gene therapy involves the transfer of genetic information into a target cells. Usually at this time, the most efficient tools we have to do that are viruses, for the simple reason that viruses have evolved over centuries and millenniums effective way to infect cells, because that's their only way to survive and to proliferate and multiply. So we have developed ways where we can kind of tam those viruses, remove the sequence in them that makes them dangerous, and use them purely for gene transfer. Oh, I haven't seen there was a gene moving in there, but we don't see it. The new gene that goes in there, which is invisible now, must be too small, is making a gene product which can be many different things, but when you design it for a specific cancer, will be designed to stop the abnormal behavior of that cancer cell, or even better, kill it. This is an example. Last week I was lecturing in this, and just before we met Friday to discuss about this, I was lecturing to medical students in this auditorium about stem cells and gene therapy. And I was advising them that unfortunately it was too late for them to change probably, but it's much easier to cure a mouse than to cure a human being. The same strategies that work exceedingly well in mouse will always work less well in humans. But that being said, these are two mice that were carrier of a melanoma. Melanoma is a very nasty, the most aggressive skin cancer. This is a skin cancer that killed Robert Bourassa. It produced metastasis very rapidly, very nasty. The difference between those two animals is that this animal here was vaccinated by melanoma cells that were killed by radiation, but were expressing an hormone that stimulates the immune system, interleukin-2. And by doing so, it provoked a much more efficient immune response in the mouse against the tumor cells. And look, these animals remain almost free of lung mets, whereas the control animal that has not received this treatment is full of tumors. And that's very important because I hate to bring an unsettling thought, but in reality, part of the question is not only why do some people develop cancer. Many scientists would say the real question is, why don't we all develop cancer? It seems that the kind of mutations that are dangerous occur in all of us from time to time. But in normal people, in healthy people that don't develop cancer, those mutations are repaired, or the immune system recognizes those cells and gets rid of them. And this is an example of how the immune system can keep you free of tumor. In conclusion, cancer research indeed advances our understanding. This understanding translates really now, presently, into effective new treatments. We still need to understand a lot more about environmental factors so that we can do better prevention. But meanwhile, I advise you to adhere to your screening programs so that we can cure you if you have an early stage cancer. Thank you.
We're a bit late, again, because of the director early on. But we'll take certainly 10-15 minutes, and I'll invite the speakers to go forward in front, and maybe you can answer all your questions. You've been very patient to listen to all these sometimes very scientific talks. So perhaps it's your turn. If you have any questions, Denis can answer more the clinical one. We can answer the basic one. Two things I want to say. With all the things we said, there's about 400 to 500 new compounds going into clinical trials now in the future. That exactly now. And this is one issue. There's so many compounds coming in to treat cancer that it's going to be a bit difficult for clinicians to know which ones to give you. So I think it's also our role to try to develop tools that they can use to choose the best one. Secondly, the rate of people cured of cancer is increasing year after year after year. Now, as I said, it's over 60% of all cancer you're cured. I think there's quite a lot of work to do, but I think we're getting there. So I don't know if you, maybe we can turn on the lights. And is there anybody which have questions? We have time now. So we'll take you first, and I'll get back to you after.
Could you develop a little bit what sort of screening programs you have? You know, I know there are multitude. So where do we find them? Should we use them in our patient? You know, is this something that is available since we see them, and we could spend maybe 2 or 3 minutes to explore this?
Okay, so I think we should repeat the questions, and I would like to Lily to answer that. If you can repeat the question. Sorry? Maybe I'll have a big conclusion on my forehead, so I think that would be good to close this like that. There you go. And you put some. I can start with this. So the question was on screening.
Yes.
It doesn't work anymore. No, I don't think it's on. Yeah, that works.
I think you only take until 8:30. Well, this one works with it. Yes. I don't know if the people present can get access to the PowerPoint somewhere.
If those which ones? I think we'll put on the web for those who can.
On the slide where I tried to, I was limited to 10 minutes, and Michel reminded me I only had 10 minutes when I got up. On that slide, you have the screening methods that are currently recommended by expert consensus. And these are the obvious ones: mammogram, pap test,
Colonoscopy.
ocular blood and stools, rectoscopy. Colonoscopy is there's less strong consensus. The reason is that most of the colon cancer will be within the reach of a shorter instrument. Other things, PSA is, there's no consensus, although it's done, I can tell it's done within the hospital. Chest X-ray, there's not enough evidence to have consensus. To do chest X-ray with someone who's not complaining of anything. Although we often find the lung cancer, usually in smokers, X-ray is done for other reasons. But that's about it. You could argue that there's should be more energy invested in identifying effective, cost-effective screening approaches. But the fact is, even the ones that exist now are not adhere to very well. Colonoscopy, you try to get an appointment to get a colonoscopy with the number of GI people we have in the country, not only in the province, it only take a year.
That's certainly a different issues, the one of accessibility. We had a question in the back here, please. It's for Patricia. Yeah, go ahead.
I'm wondering, people that carry high-risk genes, do they seem more susceptible to the environmental or viral impacts than someone who's non-high-risk gene factors?
That's a good question. So can you repeat the question, if you got it? Yeah.
So the question was if those who have, individuals who have high-risk genes, if they are more susceptible to environmental or viral, what we know from the genes that we identified for high risk, associated with high risk, is that the answer is no. So far, we find individuals with high
Thank you. Thank you. We'll go to this lady, and we have another one after gentleman. Okay, go ahead. Oh, sorry, my apologies. So, immediately after you, the next one. Thank you.
Good evening. Dr. Listy, you answered before the origins of cancer, hereditary, chemical, radiation, viral, and epigenetic. What role does the origin play in determining the treatment of a cancer? We know that some cancers can be sporadic or high risk and so forth. Does that have any impact on the treatment that can be given to the patient?
My answer, I guess, would be no. The mutation, regardless of
Speak
how,
loud, yeah.
regardless of how you acquire the mutation, is still the same.
Sort of called the same.
Yes.
But depending on which mutations, you will have different cancers, and then,
Depending on the
of course.
mutation, but if you have a mutation X that is acquired either from your mother, your father, or you acquired it from the environment, it's still the same mutation.
So once is Patricia wants to add more.
I'd just like to add that. What we're learning more and more about the specific mutations. For example, BRCA1 carriers. We know that there's specific drugs that are more effective in those carriers, such as the PARP inhibitors. I don't know if you want to comment on that, but we're now knowing, as Michel was saying, tailored therapies are now being developed because we're learning more about the function of specific genes. So, I'm guessing that as we learn more and more about the other genes, we'll have very specific tailored towards.
And I think Josie is right generally, but if you look at, depending on the type of mutation you get, it's very well known in breast cancer and HER2 that depending on which mutation you have, different treatment you'll get. So again, it depends on which cancer. And maybe in a short answer, because we want to talk about
I
this.
also wanted to add the fact that when the epigenetic effect is predominant, it opens the possibility of working on this. Probably plays a certain role in a lot more type of cancers than we appreciate now. But it's clear that in certain cases it's very predominant, and that's important.
Thank you. It's your turn.
How serious is carcinoma?
That's your question. How serious is carcinoma? We'll have to think about which one.
Carcinoma is a genetic term. Carcinoma and sarcoma refer to what cell type the cancer comes from, in reference to where those cells, the grandmother cells, were in the embryo.
Yeah, but if you're a patient and you go to your clinic,
Carcinoma of the skin, other than melanoma, is very highly curable. Some dermatologists will shave it off or burn it off, and that's it. And metastatic carcinoma of the lung is not curable. It can be treated. We can increase survival by treatment, but it's not curable. So it's a wide range of different types of carcinoma.
thank you.
What is the role of inflammation in oncogenesis?
Oh, what a good question. I was asked this at this TV show, and I kind of skate around for half an hour. I'm glad they cut my answer. So, what's the role of inflammation in cancer, oncogenesis? So, inflammation can come from many ways. I'm not sure who wants to take this answer.
We have, we've suspected for a long time that it may somehow interact with the cells that had yet to acquire mutations or started to acquire mutations. But there is very definitive evidence that comes from cancer of the stomach and lymphoma of the stomach, where chronic inflammation, gastritis, is a very important factor. One bacteria, H. pylori, which is the most common cause for chronic inflammation, is someone just try to give antibiotics, kill the bacteria off, and see if the eczema doesn't go away. In certain cases, it disappears completely.
Well, you know, I was on my dentist at my dentist about 3 weeks ago, and he says, if you don't brush your teeth, you have inflammation in your gum, and you're gonna get cancer. So I work on this. So I never heard that one, but I'm brushing my teeth like there's nobody, there's no tomorrow. So, okay, yes, you had a question.
Working in oncology as a nutritionist, you know much more about it than me.
Something that I think that you have to clarify as a dietitian, we actually don't recommend soy products to people who have PRC1 or 2 gene because of the isoflavonogens. And the theory behind soya acting as a against breast cancer, you have to be an Asian person living in Japan or China and taking soy for a long time for girls particularly form it.
Yeah, it's a very
So what was the question?
it's a very controversial, and I was hoping I made it clear that those supplements and the soybean were not accepted by everyone. I also happen to be director of the research ethics office, and recently we had a couple of projects presented involving soybean, and I can introduce you to some of our colleagues, researchers who have a strongly different view. But you know, as you said, was telling me the aspirin is increased risk of chronic cancer and other risks. I think a lot of these things, unfortunately, the data is not as strong as what would lead to an FDA approval.
We will. We're coming late in the evening, but what we're going to do, we can take one question, but after that, all the panel is here, and you're welcome. So I'll take 2 because I saw 2 hands. So we'll have you, and then you. Okay, so if you can go ahead.
My question is a general one. Decade after decade after decade, is the incidence of cancer increasing? I know that we're detecting better, so that's complicated to answer, but are we getting more cancers, or are we stable, or what?
Are we getting more cancer? Maybe Arnhem can take this question, yeah.
The rate of kidney cancer has doubled in the last 20 years. The rate of kidney cancer has doubled in the last 20 years, probably because of smoking. That's one example.
Yeah. But it depends which cancer you're talking about. I think lung is still going up. Other ones, colon cancer, because the detection is going down. It depends on which.
Yeah, it's not the same answer for every cancer. What's important is to take into account the age adjustment, because the life expectancy has increased quite significantly in the past 20 years. You know, something's got to happen at some point.
We'll have our last questions, and again, all the panels is down here, so if there's people which want to talk to them. So you want to ask your last question?
If we know that the lesions need blood support to continue to grow, is there more research done on angiogenesis, or can we stop that part of blood support and not in healthy tissues?
Well, I think you almost like a spike question in the audience, because in two evenings we have exactly an evening just on that. But you're right, there are many drugs developed to block what we call angiogenesis and the feeding of blood vessels which are going to the tumor. So it is a very important part, but so far, as far as I know, alone as a single drugs, it has not worked very well. I think people have continued to have multiple drugs, a drug would kill cells and one which would block blood vessels. So what we're looking now is these like antibiotics, where we have combinations. That's what we're going to do in cancer too. And angiogenesis blockers are very important targets in the future. So I think...
maybe the only exception, but it's are the drugs related to thalidomide. That thalidomide, that drugs that no one wanted to see and talk about, has made a very important comeback in oncology, in factor in some blood cancer in multiple myeloma. And thalidomide is effective, but has a lot of toxicity, affects the nerves, gives neuropathy. There are newer drugs, it's called the IMIDs, and one of their main mechanism of action is anti-angiogenesis, but it's not the only one. But there it's become a frontline treatment in the treatment of myeloma.
Thank you very much. So there's a few things before we leave. First, if you have a survey, write down, give us our grade. Our students grade us all the time. I think we will deserve good or bad grade. Secondly, I would like to thank Rosalind Goodman, Dale Boyman, Avi Uditsky, Hela Boro, Barbara Rosenthal, Sheila Notkin, and Annette Novak, which are the committee organizing committee. I'd like to thank Sarita and the staff of the Goodman Cancer Centre, our sponsor for tonight, and most important, our speakers, and most important, all of you that come here. I hope we were able to entertain you a little bit, not too negatively, in terms of go home thinking that most people have a good life, and we hope you have a nice life home, and see you next time. So thank you very much.